Sure.
So, good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Ali. Dr. Ali completed residency at SUNY Buffalo, followed by a cardiovascular fellowship at Ochsner Medical Center in New Orleans, Louisiana. He then did his interventional cardiology fellowship at St. John's Hospital in Detroit, Michigan. Dr. Ali is currently practicing in El Paso, Texas, as an interventional cardiologist and serves as medical director of cardiology at hospitals of Providence Sierra East Campus in El Paso, Texas. And now it is my honor to request Dr. Ali to begin today's session. Thank you.
Good morning, everyone. Can you hear me clearly?
Yes, perfect. Thank you.
Right. Well, today's topic is about peripheral arterial disease. We will actually go over a brief review of this topic, and I have tried to focus this talk at a very basic level to actually include students, residents, and early career physicians, basically. So please, next slide. So we start with the, brief description of peripheral vascular disease. This is a, group of conditions that actually include venous diseases. That is a totally different topic. Then arterial disease is the one part of that we will focus today. And among the arterial disease, the main focus is on atherosclerotic vascular disease. There are other entities like vasculitis we see in people with a connective tissue disease and other conditions, and fibromuscular dysplasia. These are two major non-atherosclerotic entities that can be cause of peripheral vascular disease, but our focus is going to be on primarily atherosclerotic vascular disease. Next slide, please. When we talk about the peripheral arterial disease, primarily atherosclerotic vascular disease, we can actually divide the vascular system in different parts of the body. There's a peripheral vascular disease involving the lower extremities, disease involving the upper extremities, then carotid artery disease, and cerebrovascular disease, primarily dealing with intracranial vessels, diseases of the aorta, renal artery disease, and then splanchnic arterial disease involving mesenterics and other branch vessels. Next. My focus today will be peripheral arterial disease involving the lower extremity. Overall scope of the problem basically is that it is estimated that about 8.5 million Americans above the age of 40 are actually affected by that. It is associated with significant morbidity, mortality, and quality of life impairment. And it is actually estimated that overall about 202 million people worldwide have PAD. This is probably the lower end of the estimate. The true incidence is probably going to be much higher. Next. So when we talk about peripheral arterial disease involving lower extremities, there are three major clinical presentation modes that we come across this problem. Apart from that, there's a significant number of people, actually majority of people are asymptomatic. They have some level of and some severity of the disease, but they are asymptomatic. But the clinical presentation is usually with claudication, acute limb ischemia, or critical limb ischemia, ALI or CLI. Next slide, please. To describe claudication, it is basically sensation of fatigue, discomfort, sometimes cramping, like patient will describe it as Charlie horses when they walk, or pain of vascular origin in the muscles of the lower extremities. It is consistently induced by exercise. So the claudication is different from the rest symptoms. It is the exercise-induced discomfort or symptoms, and it is relieved by rest. Within 10 minutes, it should actually go away. There is a condition like spinal stenosis or other degenerative joint diseases involving the lower back or hip joints, which induce pain or discomfort or cramping sensation at time. Symptoms are very similar, but the differentiation is based upon exercise. So these symptoms, claudication is always on exercise and is relieved by rest. Next slide, please. The second mode of presentation, which is really an emergency, is an acute limb ischemia. It is typically described as severe hypoperfusion within less than 2-week duration. And it is really described by 6 Ps that include pain, pallor, pulselessness, poikilothermia means cold extremity, paresthesias, and paralysis. So these 6 Ps are actually very important to remember. So if somebody has rest pain, which onset can be described as less than 2 weeks, then it can be characterized as acute limb ischemia. It is a limb-threatening condition and needs to be taken care of emergently. Next paragraph, please. In terms of describing acute limb ischemia, there are actually, once you see the patient, you can actually differentiate them into 3 categories. One is the viable limb. Limb is actually not immediately threatened. The signs of that are that there's no sensory loss, there's no muscle weakness. The patient can actually have sensations and can move their toes and their legs. And you can actually, by Doppler, you can get the audible signal on the arterial and venous systems. Next stage is the threatened limb. Go back, please. Threatened limb ischemia basically is a mild to moderate sensory or motor loss. So typically, if you ask them, they will start feeling numbness around their toes or the foot, and they will start losing their sensation to touch, and early loss of motor function with like they're unable to move their toes or their feet completely. You don't have any audible arterial signal on the Doppler examination of distal vessels, but you do still get some venous Doppler signals. And then it can be, further divided. There is marginal threatened or 2B is immediately threatened. That primarily is defined based upon presence or absence of motor loss. Third degree acute limb ischemia is irreversible. There's a major tissue loss. There's a permanent nerve damage is, impending or already occurred. There is sensory loss and muscle weakness is pretty pronounced, and you don't get any audible signal on Doppler at the arterial or venous level. Next slide, please. The third mode of presentation is critical limb ischemia. So critical limb ischemia is actually different than acute limb ischemia. It is an emergency, but acute limb ischemia is where you actually have impending limb loss if it is not taken care of. Chronic, it is a chronic disease. Critical limb ischemia is 2 weeks or more of ischemic rest pain and other symptoms. There you will see the non-healing wound ulcers or gangrene in the both legs, primarily involving the feet if it is arterial problem, the feet or the toes. And there, to define something as critical limb ischemia, you have to have evidence of arterial occlusive disease, not just by exam, but also supported by other non-invasive testing like arterial duplex. Next slide, please. So this is actually a sign. This is a, typically when you see the arterial ulcers, they involve the toes or the feet, like the side of the, the foot or the dorsum of the foot, something. So that is a, classical description of the arterial ulcer. If you have a macrovascular problem, your toes and the foot will be involved. If you have ulcers due to venous insufficiency, like venous disease, then you will typically have them at the around the ankles, lower part of the shin. And then, there are people who have microvascular disease, particularly with diabetes. So they actually may develop ulceration, but that typically involves the upper part of the shin. So that can actually help you differentiate whether you're taking care of an arterial problem or venous or a microvascular arterial problem. Next slide, please. In terms of, with critical limb ischemia, also you actually have to differentiate between types of tissue loss. Minor tissue loss is defined as a non-healing ulcer or a focal gangrene with some diffuse pedal ischemia, and the major tissue loss is like your tissue loss extend above transmetatarsal level, and functional foot is no longer salvageable. Like even if you are able to salvage a part of the foot, they will need some sort of assistance to use it for ambulation. Next slide, please. So what are the risk factors in terms of peripheral arterial disease? The risk factors are typically age equal or above 65 is considered a risk factor for people developing peripheral arterial disease. The second group is the people with the age of 50 to 64 with other risk factors which have the same atherosclerotic risk factors as you see in coronary artery disease. History of smoking is very important. Diabetes is the other one. Hyperlipidemia, hypertension, and the family history of peripheral arterial disease. In fact, some people actually, earlier investigator would tell us that smoking has such a strong association along with diabetes with peripheral arterial disease that if you see particularly a woman who's below the age of menopause and she does not have diabetes and she has evidence of peripheral arterial disease, you don't even have to ask her, you just document that she's a smoker or she's an ex-smoker. It's a very strong correlation with the peripheral arterial disease. Age under 50, people who have diabetes plus one additional risk factor, and the people we see are the most common additional risk factor is smoking. Smoking actually has a very strong association with peripheral arterial disease also. And then, if you are just looking at the lower extremity peripheral arterial disease and you want to decide whether you need to, patient is asymptomatic, suppose, but you want to decide whether we need to look at peripheral arterial disease as an entity in that patient, then people who have atherosclerotic disease in any other vascular bed, they should be screened for peripheral arterial disease with non-invasive testing. Remember, atherosclerosis is a systemic disease. It may only manifest in one part of the body, but other parts of the body almost always have some evidence of the disease. Next paragraph, next slide, please. So how do you evaluate the patient? It's the same evaluation which we do with every patient. It actually starts with the history. This history is about, apart from the general medical history, you focus on certain things. One of them is claudication. Do they have leg weakness, discomfort, numbness when they ambulate, and does it go away when they walk? When they stop walking, impaired walking function. Some people actually don't have dysfunction like discomfort or pain, but they will describe that after walking a certain distance, their legs just become really weak and they think that they're going to fall. People who have developed ulcers on their legs, if there's a poor wound healing, that is an indication that we may be dealing with peripheral vascular disease. And then, of course, ischemic rest pain is a sign, a clue that you're dealing with an acute manifestation of peripheral arterial disease. Next slide, please. So the vascular examination, apart from your general physical examination, there are certain things which should be done if you're particularly, in most cases, but when you are suspecting somebody with peripheral arterial disease, you're examining them. So always palpate their pulses, palpate their femoral, popliteal, DP, and posterior tibial. Now remember, dorsalis pedis is actually absent in a significant number of people without any disease. You may not be able to palpate, particularly in older people. Dorsalis pedis pulse is not palpable. There may not be any significant disease. But if you have absence or weak posterior tibial by Doppler, then that may be a clue that you're dealing with a peripheral arterial disease. Always auscultate for femoral bruit. I mean, distally, it won't be really easy to auscultate and you may not actually hear anything, but presence of a bruit in the femoral arterial areas may be an indication of the peripheral vascular disease. And always inspect the legs and feet for the sign of, chronic ischemia. There's maybe hair loss, there may be reduced capillary refill, some erythema, some pallor, or there is, development of early ulcers, erosions. So those type of things, always look for those. Next slide, please. So apart from, those things, the vascular bruise, there will be non-healing wound, there may be evidence of gangrene. So other is, you actually do the elevation. If you elevate the foot, they become pale. And then you also see dependent droop. If the patient sits for a little bit, you can actually see this droop developing around their toes and the feet. So these are signs that there may be peripheral arterial disease, which may be significant. Next slide, please. So what do we do once we have history and physical suggestive of peripheral arterial disease? So the best test that can be done at the bedside is the resting ABIs, is ankle brachial index. Basically, what you do is you take the blood pressure, brachial arterial blood pressure on both sides, and then you take the blood pressure by Doppler of the posterior tibial and dorsalis pedis, and you can actually use the higher reading of those to decide what is the index of arterial brachial pressures. The other are segmental pressures and the waveform. Next slide, please. So as I said earlier, the ABI is measuring the blood pressure in the arms and lower extremities and just getting an index, dividing, ankle pressure with the brachial pressure, and that will give you a number. With the history and physical exam, when it is suggestive of PAD, the ABI is a pretty good test. It's an easy test. All you need is a blood pressure cuff and a Doppler, handheld Doppler. You can actually do it at the bedside. It has a, pretty decent sensitivity and specificities, the specificity particularly ranges from 84 to 99%, which is actually very good. The other test is a segmental pressure. You can actually do it by measuring blood pressure with a Doppler signal at different levels of the thigh and below the knee. And the changes drop in the segmental pressure will be actually indication of peripheral arterial disease, and it can actually give us an idea about localizing the disease by non-invasive evaluation. Next slide, please. So the resting ABIs, which is, should be done in almost every patient who has suggestive symptoms and signs of peripheral arterial disease. The normal range is 1 to 1.4. Anything below equal to 0.9 or below is considered abnormal, and 0.91 to 0.99 is considered borderline. A lot of people actually have ABI, which is greater than 1.4. They basically have non-compressible vessels. So this test becomes useless in those cases. Medial calcinosis, a patient with chronic kidney disease are the classical example. Their arteries are so calcified and stiff that you're actually not going to get a decent ABI result from them. So if somebody has, symptoms suggestive of classical claudication, but their ABIs are above 0.9 or their normal range, but you are actually convinced that this person has peripheral vascular disease, significant peripheral vascular disease, the next step, what we can do is we can actually do an exercise treadmill ABI to evaluate for peripheral arterial disease. You basically have them walk on the treadmill at a certain level for about 5 minutes, and you test their blood pressures, check their blood pressures during, before, and after, and a drop in the blood pressure will indicate at the ankle level will actually unmask the disease, and your ABIs will become abnormal. Next slide, please. And exactly, exertional ABIs is actually a very good tool of assessing patients' exercise capacity before and after treatment also. And it is actually one of the things that we can actually test if we do some type of intervention, mostly endovascular these days, but surgical revascularization, and you want to see their exercise capacity, then exercise ABIs are actually one way of testing their exercise improvement in their exercise capacity. If you don't have if you're doing an office-based practice when you don't have a treadmill, then a 6-minute walk test is a reasonable alternative. 6 minutes walk test is actually used for a lot of cardiac and pulmonary functional status assessment. It is a very simple test. All you need is you need to mark in a hallway, you mark the distance from one point to the other point, and you let the patient walk for 6 minutes at their own pace. To make sure if you're doing that you have, if it's a relatively long hallway particularly, you have some areas where there's a chair available for them to sit. All patients have to do is to walk for 6 minutes. They can sit down, take rest as many times as they want during that 6 minutes. And at the end, you basically calculate the distance they have walked. And that actually has prognostic implication when it comes to the people with heart failure and people with severe pulmonary diseases. It is also a very helpful test for getting an exercise ABIs. You check their ABIs before and the end of the 6 minutes, and that can give you an answer that's sort of a poor man's stress ABIs. Now, the patient who cannot walk, you can actually do sort of series of extension and flexion of your ankle joint, and then check the pressure difference before and after that. That is also an alternative to doing an exercise, a treadmill ABI testing. Next slide, please. Now, in patients who have, clinical exams suggestive of PAD, other things clinically are suggestive of PAD, but their ABIs are not, measurable because of stiffened arteries like medial calcinosis, or, you want to determine whether there is something else associated with the symptoms, apart from the peripheral vascular disease, then there are certain actually tests we can do. And some of these tests actually are done to decide whether we need to intervene in a patient who has suggestions of critical limb ischemia. If they have non-healing ulcers, we actually need to do these tests to decide if the vascular intervention will actually help or not. So TBI, which is a toe brachial index, they actually have a small cuff that you can put on the big toe, and you can measure the pressure of the big toe with those cuffs and calculate the toe and brachial index. That is actually a good measure for that. The other test is TCPO2, which is transcutaneous oxygen level, or systolic perfusion pressure. These are the tests you can do. And if the toe pressure index is less than 30 millimeter, or if the oxygen TCPO2 is above 30, it actually TCPO2 above 30 indicates that there is a decent chance of the ulcer healing with the wound care. And the TCPO2 below 30 will actually tell you that despite aggressive wound care, you are not going to see wound healing unless there is revascularization, unless you take care of the underlying disease with some intervention. And so these tests also, TCPO2 particularly, is also actually helps us to target our intervention. So if there's a certain level of TCPO2 drop, that tells you where you need to work on to improve that. So these tests are actually very helpful, and that TBI of less than 0.7 is predictive of significant peripheral vascular disease. So these are the more specialized tests that need a vascular lab to be done. But ABI is a test that you can literally do at the bedside. All you need is a handheld Doppler and a blood pressure cuff. Next slide, please. There are certain other tests apart from these tests I described that we can do to determine the extent or level of the revascularization or define the anatomy, and that actually duplex ultrasound will give you the waveform, whether it's a monophasic, biphasic, triphasic waveform that actually helps us in terms of determining the significance of the disease and localization of the disease. CT angiography is a very good test. The problem is it still uses contrast, so the people with renal impairment will still have to deal with that. And MRA is actually also helpful, although the very distal foot, it becomes sometimes problematic to interpret that. So you really need a very good center who's used to doing tons of MRAs to actually give you a good results with that test. Next slide, please. So in terms of, once you have established somebody has peripheral arterial disease, we are actually now, obviously, we have to look for the management plan. So the management plan actually goes from one spectrum of exercise program with some medication to the other extreme of revascularization. So there are 4 options. You can actually say exercise program, risk factor modification. Like for every other cardiovascular disease, you have to work on the risk factors, drug therapy, drug management, and revascularization. And every patient will get a combination of these depending upon their clinical status and presentation. Next slide, please. So the exercise program, typically when we like to prescribe exercise as a part of the treatment plan, we like to start as a, more of a structured exercise program to be done at some exercise facility like cardiac rehab facility or some other exercise training program facility, at least initially. And I think the 3 months, like around 12 weeks, is a minimum requirement to see some improvement. But in some cases, what we do is we actually have a patient attend only a few sessions if they are not able to, one of the major things is the transportation to and from the center may be an issue for elderly people. So we ask them to attend a couple of sessions so get used to it, and then they can replicate that at home. For the peripheral arterial disease, it's actually a very simple test. What they do is the whole session is about 30 to 45 minutes, and what you ask them to do it at least 3 times a week. 12 weeks is the duration we recommend. Training is very simple. It's bouts of walking, moderate to maximum claudication. So what you tell them is to walk until they start getting moderate to severe symptoms of claudication, then stop. Claudication disappears, walk again. So they spend doing this thing about 30 to 45 minutes in every session. It's like any other, training in exercise and your lifestyle modification training. What it does is it actually improves their claudication distance because their body response is to improvement in the collateral flow with the exercise and perception of the patient of the pain gets better. So that's actually, it's a very simple way of doing a program. Exercise program doesn't require any equipment, anything like that. And patient can actually do it at home after a couple of sessions when they get used to like what is expected of them to do during the session. Next slide, please. Risk factor modification is a very important part of any vascular disease like a cardiovascular disease. Lifestyle modification that involves diet, smoking cessation is very important as part of the lifestyle modification, and regular exercise. Weight loss is also an important part. Management of diabetes needs to be optimized. Blood pressure control needs to be optimized. Statin therapy. So based upon the risk calculation, if you have atherosclerotic disease, you basically will need to be on statins, and it's a lifelong prescription. And typically, one mistake we see in the community that people tend to stop their statins once their cholesterol level is down within normal range. But this is something it's likely will harm them because the cholesterol tends to get up higher up again. And we are actually, yes, we are looking at a certain target level, but we are not paying too much attention to the number in people who have low normal cholesterol to begin with. It is the way the statins act is more important. They not only decrease the number, they don't only decrease the LDL count, but they also make your cholesterol behave better, and they also have good, therapeutic effect on the endothelium. So they improve the endothelial function of the blood vessels. So it's a lifelong commitment if they can tolerate it. If they can't, then there are other alternatives. Now FSCAI inhibitors are available. Other alternatives are available. And in the end, the smoking cessation is extremely important. Everything else will go down the drain if they continue to smoke. It is one of the most important things they need to do is to stop smoking. Next slide, please. In terms of drug therapy, there are, different drugs that are available which we use for these people. Antiplatelets are the mainstay of treatment. Aspirin, clopidogrel, ticagrelor are the few drugs that are used. If patients have some atherosclerotic disease, but they are asymptomatic, there has been question whether any antiplatelet is needed, and really it is not recommended these days. We used to use aspirin fairly routinely for primary prevention, but the evidence is that it may not be, beneficial, and there may be some harm. Similarly, other antiplatelets also, and there is evidence that low-dose anticoagulants like rivaroxaban at the dose of 2.5 milligram once or twice a day may be more beneficial than antiplatelets. So this is something that the data is actually evolving, and in the next few years, we will have a lot more different options available. The other drug that is used very commonly in people with peripheral arterial disease is celestazole. It is an antiplatelet. It has a similar effect as clopidogrel, but it is also a vasodilator. And it used to be the mainstay of the treatment for people with peripheral vascular disease, but there are suggestions now with the new data is coming up that, maybe rivaroxaban or the similar anticoagulants may have a more beneficial effect. So this field is actually evolving. Pentoxifylline is actually a Trentol. It's a very interesting drug. It got approved at the time when you really needed a very few patients to study and show it to FDA. On balance, there is no evidence that pentoxifylline actually improves any symptoms in patients with peripheral arterial disease. When you look at a lot of the other studies and look at some of the meta-analysis, we do see something that some people who have been on pentoxifylline for a long time, if you stop that, they start complaining of claudication, whether it is a sort of a placebo effect phenomena or true phenomena. We don't know. I don't think there's any evidence one way or the other. So if somebody is on that, we try not to stop it most of the time. Now, pentoxifylline has some other newer indication for people with severe, lung disease and people with hepatic cirrhosis. That's a separate topic. In terms of anticoagulants, as I mentioned, rivaroxaban is being studied a lot. Some other NOACs are being studied. And there is evidence that low dose of these, agents may be more beneficial than some of the antiplatelets. So this is an evolving field, and we actually choose different things in different patients. If some patient had an endovascular intervention, they have like particularly atherectomy, balloon angioplasty, or somebody received the stent in their lower extremities, then yes, they need to be on dual antiplatelet for a certain period of time, and then a single antiplatelet for now, although rivaroxaban may actually substitute that antiplatelet agent in some cases. And then in the end, there's always a hype about chelation therapy, but chelation there's no evidence that it works. I mean, there is no way that you can infuse something and that will dissolve your plaque and it will disappear. There is no really logical explanation of that. The way the plaque builds up and develops, you're not going to have something that's going to dissolve your plaque and then make your arteries free of any disease. So that is talked about, that is hyped, and it's actually some people in different non-physician entities even recommend that in some cases, but it is not something that helps. We do get asked about it quite frequently. Patient will come and bring some sort of, little flyer that, what about this? Can I do this and avoid all these medications and treatment? The answer is obviously there's no evidence. Next slide, please. The other thing is actually, this is this whole topic in itself about the revascularization. Revascularization means that you will open up the, the blocked arteries, surgical or endovascular. As is the history of medicine, it used to be surgical. Everything moves from invasive to less invasive, non-invasive entities. So the bypass for lower extremity disease, the FEMPOP or aorto bifem bypass or distal bypasses, they are very, very rare. One of the reasons is that it's an extensive surgery. Number two, surgical intervention does have longer term, implication in terms of need for revascularization. And this is something we have seen, that if endovascular intervention, which basically means balloon catheter-based intervention, you do angioplasty or you do stenting or different type of angioplasties or atherectomies, if that fails, then the patient still has option of surgical revascularization as a very viable option. But once the surgical revascularization bypasses start to fail, the disease usually has become more extensive and they may become more of a problem in terms of the type of intervention they need. And the outcome, long-term success of the intervention may not be as durable as in other cases. So I'm going to stop here and take any questions. Thank you very much.
Yes. All right. Thank you, Dr. Ali, for that. So my name is Amna, and I'll be doing the first part of your Q&A session. I'm an undergraduate student at the University of Maryland. So our first question is, what is the difference between peripheral arterial disease and peripheral vascular disease, and how do you diagnose them differently?
Can you hear me now?
Yes.
Okay. So what the difference, as I mentioned earlier, basically peripheral vascular disease is the global any type of circulation. Arterial disease is talking about the arterial tree. So the vascular disease will also include, your venous disease. So they have different manifestation, like whenever you have problem with the venous circulation, either there is a reflux or they have venous thrombosis. One of the symptoms is the swelling of that affected area. That is not the classical symptom of the arterial occlusion, because once the swelling develops in the arterial occlusion, you are basically looking at a dead limb. If there's an arterial occlusion that happened and you're developing swelling because of that, edema because of that, then you're basically looking at the dead muscle and dead limb. So it's, the arterial venous duplex is a standard study to do that. So that's the basic difference, is that vascular means all type of circulatory system. Arterial disease, you're just looking at the arteries. So yeah.
That makes sense. Thanks for the clarification. Our next question is, excuse me, how do you collaborate with other healthcare professionals in your career, such as vascular surgeons or radiologists in the treatment of patients with PAD?
You want a political answer or a truth? So, I mean, the practice of medicine is, we do have good and bad collaboration, because it is almost becomes, depending upon your setting, so there are institutions where they have actually every entity or specialty has very defined roles, that who treats this and who treats that. Now, the vascular diseases of, cardiologists treat that. Actually, majority of the peripheral vascular disease nowadays, endovascular is done by the cardiologist, taken care by the cardiologist. Then vascular surgeons do that. Cardiothoracic surgeon also do some vascular, and interventional radiologists do a lot of, interventions and treatment of that. So we try to, and it's the good idea for everyone to try to build a sort of a team approach. So have an open channel of communication with each other, so it doesn't become like more of a political, battle between who gets this patient or who gets that patient. But unfortunately, that does not happen all the time. And particularly when the endovascular treatment was being introduced and the surgical treatment was becoming a second option, there was a lot of, turf wars about who will do what. And it took like years and years to basically settle things that, okay, this is the training that is required. Whoever has the training should be able to take care of these patients. So yes, we try to do it's always a good idea to have a teamwork, have a vascular team. And it has actually started happen when different institutions and our own institution we have developed, like one of our colleagues has developed, who actually led that, uh, what we call a limb ischemia program, critical CLI program. So we actually include surgeon, vascular surgeon, we include interventional radiologists, we include the cardiologist, vascular physician, we include podiatrists and orthopedic surgeon, because podiatrists are podiatry and the wound care people, because they are the one who we do the more glorious part, like take care of this quickly, quick fix, open up the artery, do whatever. But they are the ones who have to take care of the patient in the long term in terms of wound care, follow up, everything. And somebody who needs amputation, depending upon the availability of the skills, it may be, a trauma surgeon, or it may be an orthopedic surgeon, or it may be a podiatrist who will do that type of amputation depending upon the location of the amputation. So they are part of that. So those programs have actually helped developing a team approach, and they have actually helped patients in terms of not getting lost after one encounter at the hospital and then they go home and there's nobody following them. So now we actually have in different places those programs, and that actually helps the patient care and outcome.
Yeah, that makes sense. Seems like vascular diseases definitely require like a great involvement with plenty of different specialties. So thank you for that answer. Our next question is, what are some clinical indications of using warfarin for anticoagulation in patients?
Well, warfarin is actually one of the oldest drug, for anticoagulation. So the warfarin for the arterial disease is used primarily if you have evidence of any thromboembolic problem. So upfront, now we are actually, as I mentioned, we are actually getting with the newer drug NOACs with the, rivaroxaban is one of the agents that a low dose we are using as a prophylactic treatment as an alternative to antiplatelets. But for warfarin, the main use has been if somebody had an evidence that they actually developed acute or subacute limb ischemia that was associated with thrombotic occlusion or embolic occlusion because of atrial fibrillation being the commonest cause, then they will need to be in anticoagulation. So warfarin was the only agent available, and they will be on warfarin. Now we have the alternative of the NOACs like rivaroxaban, like apixaban, those drugs, they are actually available. So we decide about availability. A lot of factors are there. One of the which one is the safest and the most beneficial, and then the cost, how the patient is going to cover the cost, all those things come into account. But there's no, warfarin was never used as a prophylaxis just for the PVD in most cases. And one of the reasons was, there was no evidence that it will actually help. Number two, it will not help unless you have the evidence of thrombotic occlusion or embolic phenomena. And number two, warfarin was one of the reasons the other drugs came into market and were more popular is very cumbersome to manage for the patient. There are a lot of dietary restriction. Then there are a lot of, regular blood testing is required, all those things. So that actually do that. Now, while we are on this topic, interestingly, there is a new drug. There are a couple of them are actually coming out into now phase 3 trials, which may change the way we use anticoagulation. These are factor 11 and 11A inhibitors. So those are the drugs like, what we call the medical Goldilocks, that they actually have perfect safety profile. The risk of bleeding is extremely low, and they are very effective as an anticoagulant. And that has to do with the mechanism and the point on the, the coagulation cascade, all those factors of the end, coagulation factors from the tissue factors, contact factors, all those, the point of interaction where they act, you can actually, in the simple words, I can say that your coagulation pathway can be described in two groups. One is the tissue factor and the other one is the contact factor. The contact factor is what you can say is the pathological response, that your body starts generating clot for whatever reason, blood stasis in atrial fibrillation in left atrial appendage and left atrium will start generating a thrombus, and that can embolize, those type of phenomena. Tissue factor is your body's defense mechanism. Every time your body has an injury, it gets activated and you actually have so simple cut will not let anyone to bleed to death because the body will thrombose that area, will protect that. So the factor 11A inhibitors selectively act on the contact factors. So they will actually, primarily, the data shows that their effect on the pathological pathway is extremely strong. So they give the benefit of the treatment, what we are looking for. They give us the anticoagulation to prevent those phenomena, and they have very minimal effect on the tissue pathway. So your body's capability to prevent you from bleeding uncontrollably is actually preserved. So your body defense mechanism is maintained while the pathological pathway is attacked. We'll see how it pans out in the bigger trials, and they may actually change the way we use anticoagulation in the near future.
Yeah, that's very interesting. There's so many different factors that come into play when deciding even just what anticoagulation to give to patients. So that's very interesting. Thank you. So our next question, you mentioned there's advancements in your field constantly, especially related to medicines. So could you share some insights on the latest advancements, in the research of treatment for different cardiac conditions that you find particularly promising or exciting?
Well, I think in terms of the medication, I told you one thing is that anticoagulation, world of anticoagulation may just change completely if the factor 11A antagonists pan out to be what the smaller trial have shown them to be. There are, newer antiplatelets, antiplatelet drugs coming down the horizon. There are cholesterol management strategies which are being developed, but a lot of them actually are very effective drugs. But the problem with them is that their toxicity is not, acceptable. So they show promise and then they never take, the path to become a clinically relevant intervention. In terms of non-medicinal treatment, in terms of intervention, I think there are new modalities available. One of the things that we have actually over the last few years become more available and we are using more and more, treating the coronary artery disease and the peripheral vascular disease is the what we call the shock wave treatment. It is the intravascular lithotripsy. It is the same concept and same type of treatment that urologists use to break up the renal stone with the electrical shock. Now we have the capability to use them in the arteries to break up the calcium, and that makes the intervention much more, simpler and safer. So that is one of the new advancements that came. And the other thing that is actually becoming is more and more, common in terms of treatment, which is in the cardiovascular medicine, is in the field of structural heart disease. So until 20 years ago, the concept was still 24 years ago, it was still a concept on the paper. People talked about it and people thought it was going to be very difficult to do that. So instead of getting surgical valve treatment, like if you have aortic stenosis or if you have mitral regurgitation, if you have tricuspid regurgitation, instead of getting surgery for that, we have the capability of take care of those problems is a catheter-based treatment. Like we can actually replace the valve, aortic valve, or we can basically put a new valve in. We don't take the older valve out like the surgeons do. We can actually, with the catheter just going through your carotid artery or going through your groin, femoral artery, we can put a new valve at the aortic position, and that actually takes care of the problem. It's a very effective and very successful treatment, and it has basically changed the, way the aortic valve disease is being managed. That is increasingly becoming the first line treatment. It was developed as a treatment for the high risk people who are not, capable of going through the surgical valve replacement. Similarly, mitral valve regurgitation can be taken care of. Now, mitral valve stenosis can be taken care of by putting a catheter-based valve, and the tricuspid regurgitation is the other thing that we can actually take care of. So those are where the major developments are coming out in medicine. And, there are always new drugs in different fields which are on horizon, but a lot of them are, except like 11A inhibitor, which is a totally new revolutionary concept. A lot of those drugs are, going to be improvement, like a different generation of statins or statin-like drug, or different type of PCSK9 inhibitor or that related drug. So it's an improvement on the concept, but there are some revolutionary things coming out.
Yeah, that's so interesting. Thank you so much for sharing. So now I'll be passing it off to Jocelyn, who will be wrapping up the Q&A session with questions about your career. Thank you.
Hi, Dr. Ali. My name is Jocelyn.
Hi.
I am a recent graduate from Georgetown University with my master's in physiology and biophysics. So we're going to be moving on to questions more about your career. So what inspired you to pursue medicine, and why did you choose to specialize in cardiology?
I think one of the things that, inspired me to go to the medicine was that when I was growing up, there was a surgeon who lived across the street from us, and we always thought that, he's really a cool career, cool person. So a lot of us in that area actually decided to go to the medicine. And then my family, there were a lot of people who were going to medical school, including my elder brother and a lot of cousins. So that was a path I decided to choose. And once I got into it, so the cardiology I found very, interesting topic. And so that basically became the focus of my career.
Great. So what type of procedures do you perform as an interventional cardiologist?
I do actually, so I do coronary intervention. So anyone who has coronary artery disease, heart attack, anything like that, if they need an angiogram and intervention, angioplasty, stenting, or different treatment, I do that. I do the similar treatment for vascular disease, peripheral vascular disease. And then I also do structural like aortic valve intervention, and what another treatment actually I forgot to mention, which has come into horizon, is called a left atrial appendage occlusion. So 90% of the thromboembolic complication associated with atrial fibrillation, which is a very common disease in the elderly, atrial fibrillation, 90% of the thromboembolic complication actually arise from the left atrial appendage. In 90% of cases, we're talking about non-rheumatic. People who have rheumatic valve disease, they have slightly different mechanisms because their valve itself can be a thrombotic entity after it is affected by the rheumatic fever. So non-rheumatic atrial fibrillation, 90% of cases of thromboembolism actually arise from the left atrial appendage. Anticoagulation was the only thing, but nowadays we actually have option. We have a couple of devices available that we can go from primarily the femoral vein, do the transseptal puncture and go to the left atrium and put a small plug there, nitinol plug in that area, that over a few weeks becomes endothelialized, and then the patients can stop taking anticoagulation and they can actually just take some simple antiplatelet like 81 milligram of aspirin daily, and their risk of their thromboembolism is almost the same as somebody who is taking anticoagulation. So that is actually one of the procedure I do. So those type of things actually are part of the practice.
And since you mentioned the importance of patient education in your presentation, can you elaborate how you engage and educate your patients about the condition and treatment options?
Well, I think it is a teamwork. So we have, in the hospital, we have the group of people who work with the rehab program, and then with the dietitian. All those people actually work with the patient. In the office also, we have some nursing staff who spend time with the patient about these things. And we ask patient about the question and try to, explain to them. This is actually the hardest part, is to explain to the patient that whatever we do in terms of very expensive and invasive intervention will mean nothing in the long term unless they change their behavior and they change their lifestyle. And that is actually the hardest part, and one of the things that I find really, frustrating and amusing at the same time, that the patient may have had number of heart procedures done or other procedures done, and they do not remember anything about that. They literally will have no idea, okay, what was done. It's like, they remember when and where their car batteries were changed, but they will absolutely not remember where did they have their open heart surgery in some cases. In a lot of cases, where did they have their heart procedure done? Why was it done? What was done? So that is, I think, one of the biggest challenge in medicine, is to educate the patient that they need to take control of their own health. And part of that is knowing what they have and how it's being treated, and what is the expectation on the part of the doctors, on the part of the patient and everyone, that how things should be done.
Thank you. So what do you think is the most rewarding part of your job as an interventional cardiologist?
I think the grateful patient and their families, when you take care of something, and something, particularly people who come in with the heart attack are the one that, see that immediately they are coming in having a heart attack, and they go to the cath lab, and about an hour later we come out and tell them everything is fine. And patient is also sitting up talking. So that is actually the rewarding part. So.
Thank you for that answer. So for our last question, what is some advice that you would give some students who are interested in pursuing cardiology?
Well, do it. It is, it is hard work. It's a very extensive training. And at least initially, when you start practicing, it will be very long hours. And depending upon what you want to do in cardiology, it may be long hours all the time. But I think it is worth doing if it is your passion and if it is something you want to do.
Awesome. And for the, balancing your life, how do you think you manage your work-life balance when it comes to all the hours in cardiology?
Well, I think so once you become interventional cardiologist, there's a lot of things. The balancing may become very difficult. You just have to, I think one of the things you need to do is try to develop a good team around you. So you actually have people who cover each other. So you're not the only one who's doing everything. And so that is actually says, yeah, you have to, make an effort to balance things. So, spend time outside of the work doing something different. So
what are some of your favorite things to do?
Well, if I get the chance, I like to travel. I like to get out of the town and go some different places. That is one of the things. And like everyone else, I'm actually trying to get into more and more into golfing. So I think for some reason, human beings get a great play at hitting a ball aimlessly.
Yeah. All right, thank you so much. And those are all the questions that we have for today. We would like everyone in the chat to give a warm thank you to Dr. Ali for his informative session. Thank you so much.
Thank you. It's a pleasure.
Now we're going to go and conduct our closing session with our quiz and future session dates. The link to this quiz for the session is now live, and you will need a 70% or higher to pass and receive the certification. And next on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. And our next session will be live. Our next live session will be Saturday, October 21st at 10 a.m. Eastern Standard Time for another cardiology session, part of our cardiopulmonary month. Thank you guys so much for attending today's session. We hope to see you in upcoming sessions, and this concludes this week's shadowing session. Thank you.